Okay.
Hello. Can you
Hello?
hear us Mario?
Yes, good morning, Dan. Good
Good
morning.
morning.
We can hear you very well.
Super.
Okay. Is anybody in the room or everybody still sleeping?
People are still coming in.
More or less. Okay. We go straight to the first case we have here. Well, I like to show you Lucien and Luca on my right. Francesca Pluchinota will introduce the case, and this is going to be an ASD case. And if you go with the camera, watching Aki Ludomischi and Angelo Micheletti, they will perform the echo transesophageal echo for us. So I pass the word to Francesca to introduce the case. Please, Francesca, go ahead.
Good morning, everyone. The first case is a 5-year-old female with a diagnosis of atrial defect, normal growth, no other comorbidity. Here you can see a short, a subcostal view showing the defect, interatrial defect with a left-to-right shunt. Here is a short axis view, again showing the defect with a good aortic rim. And the last is a 4-chamber view, and you can appreciate from the 4-chamber the enlargement of the right ventricle. It's
Done. Looks
Yes.
like moderate size ASD with good rims, where theoretically it's going to be a straightforward case. I think now it's better to pass to the echo pictures, and Aki will describe the case. Please, Aki, go ahead.
Good morning, everyone. So we use the biplane here because the patient is relatively small to put the multiplane probe. And we got several pictures that we're going to share with. So moderate size ASD, left to right shunt. It's definitely one part of the septum itself is more floppy than firm. So we'll give you the measurement pretty soon. We went to a bicaval view also, and here is the aortic rim that looks pretty good. Atrial septum is really measured between 1.4, 5, 1.6 and the total atrial septum is about 2.3. Again, measurement here between 1.3 to 1.5. Pulmonary veins are okay. Couple of more measurement. Doppler indicating left to right shunt. No mitral regurgitation. The ASD here, including the floppy and the firm, measure 1.6. Left lower pulmonary veins are fine, left atrial appendage, normal flow in the pulmonary veins. We can even demonstrate coronary flow. Practically, as I said, the measurement is between 1.5 to 1.7. Then, Mario, should I discuss the ballooning, or are you going to discuss the ballooning?
Yes, well, any comments, questions, Don, from you, the panelists, and the audience?
Yes. Any?
Yes.
It looks like nobody. I have a question to Aki, if he can answer me. On transthoracic, it seems that the defect is larger than it looks in the TEE. Did we look at the IVC and the inferior rim completely on a sweep? Or Aki thinks that it's only a single defect?
No, there is, I think it's a very good question. I didn't look at the transthoracic, so I cannot refer to that. But we also thought that maybe there is a small defect next to the
But
SVC.
I don't think the measurements were much different from transthoracic.
No, I'm saying
I
think the question was either we have an additional small defect,
right.
I believe, and I think we showed it very clear that the answer is no. It's just a floppy part of the atrial septum.
So we have a question here, Allison.
Good morning, Mario and
Good morning.
Aki. It's Allison. I just wondered,
Yes.
with the really nice echo views and the fairly well-defined rims, would you consider just choosing a device size and perhaps not balloon sizing in this patient?
Yeah, that's a very expected question. I agree with you that in this kind of anatomy with pretty defined rims and very nice pictures on echo, balloon size is not mandatory. We do balloon sizes routinely, so it takes just a couple of minutes. So we actually did balloon sizing also in this case. And I showed you the picture now of the balloon on fluoro.
I think, Mario, if I can interfere for 1 second. I think
Yes,
it's,
please.
It's definitely good to take the balloon in both projections, the equivalent for chamber and also in the longitudinal, because then we can assess the waist
Right.
much better, and usually the waist will correlate very well with the balloon sizing of the angio, of the fluoroscopy, sorry.
Yeah, that's right. So you see now the balloon, show you the measurements. Well, we measure just a so-called stop flow technique. However, we had a nice indentation on the balloon going from 15 to 16.
Nice, very central, localized.
Very central, and with this picture, Aki, can you show us the echo with the balloon? With
Yeah, so
Yeah.
we did that.
Was this stop flow then?
Yeah. Okay, we can see the balloon in a couple of projections here. Okay. And again, go to the bicaval to 90 degrees from here. You can see very nicely the waist from here to here. And it definitely correlates very nicely with the measurement that we got from the fluoroscopy.
Yeah, Aki, going back to the Ellison question, as expected, the measurements taken by echo are almost the same with the balloon sizing, so around 15, 16 millimeters.
yeah.
So I agree with you that in this case, balloon sizing is not really mandatory. So we are
did you have
here. Yes.
Did you have a particular device you had in mind here? This is a very nice case anyway.
Well, we're going to use an Amplatzer ASD occluder. Aki, what size would you suggest?
I go for 16.
16.
Yeah.
Aki is suggesting 16.
16 what?
What about 16 millimeter ASD occluder? What do you suggest? Can you show the measurements we've been taken by balloon sizing? Well, we are in doubt between 15 and 16. It doesn't make a huge difference between the two. What do you think?
Yes, I think a 15 or 16, but I guess
15 will be enough.
so it would take if you use the
Dan, excuse me. Unfortunately, we don't have 15 and a half device. So.
Mario, this is Mansour. There are the two measurements. One of them is between the two dots, and one is the stretch diameter. And so
Well-
the stretch diameter is the smaller one, I take it?
Well, actually, you see an indentation, but it is not the really stretched diameter because you see now, can you see now the balloon? Going back and forth very easily with almost no pressure. And there was indeed an indentation, but without stretching anything. Aki, would you comment on that?
Yeah, I think you're absolutely right. There was an offload without the indentation. So again, I think 15 will be enough, but I think in this case we're pretty far from the tricuspid and mitral. I think 16 will be okay, but that's...
Okay, Aki suggesting 16. Would you agree? Or if you don't, well.
No, I think it seems.
Don,
we can
what do you
ask-
think?
We can ask the audience, people who want. So you have 15 size or anyone? People who voted. Who wants something bigger? Bigger. So there are more voted for the 15.
15 or 16?
15.
15. Aki, shall we follow the audience in?
Absolutely.
Okay, Aki would agree that 15 is going to be enough, so we select the 15. All right. Please give us a 15 millimeter ASD occluder, please. Okay. Now Lucien and Luca will load the device. Can you go with the camera to the table? Lucien and Luca will load the device.
It's pretty good, huh? Give us a nice view.
While they are loading the device, there are additional questions or comments.
So this is the regular implants.
Yes. While they are loading the device, I'm introducing the long sheath, which is not very interesting to see.
I think Mario, one of the most important steps of this procedure going to the left side is actually the entry to the left atrium with the sheath. So if we can ask the director just to put the fluoro on, so we'll see Mario how.
Okay. Well, this may be an important point. So let's go back to fluoro. Well, the wire is in the left upper pulmonary vein, as you see. I'm advancing the sheath, entering the left atrium. Now I'm advancing the sheath, withdrawing the dilator. Well, one important step is to avoid air entry. What I usually, my preferred technique is just to withdraw the dilator, leaving a wire inside, and let the blood coming out of the sheath.
Exactly as my.
Yeah, a backward flow, keeping the sheath below the zero line. Can you go to my hands, please? You see? Well, I don't want to
Yeah, we see that clearly.
bleed that much. Well, I think this is the most simple way to avoid air entry without too many washing and aspirate, etc. So we connect the.
Nice.
How many times you draw the dilator at the lower part, the upper part of the IVC?
Well, I usually don't do this. I did not experience any problem in advancing the dilator up to the left atrium. So let's go back to fluoro now. Ok, passiamo le luci un pochino fuori. Okay, I'm advancing. One, a routine, very simple, but I think very important step. Sometimes you may come across of not having loaded the device firmly on the delivery cable. So just to make sure it's still attached, I'm advancing, withdraw, and re-advancing. So now we are sure that the device is firmly attached to the delivery cable. Okay, so I'm going ahead, deploy the left disc. Can you see picture in picture? Yeah, echo and fluoro. Probably it's better to have large fluoro and small, well, large echo and a small fluoro, picture in picture. Can you see that now? Well, Aki, would you like to make a comment about the best projection you suggest for deploying the device?
I think the best projection is the one that you and the catheterizer are on the same page. Some people like the equivalent for chambers. Some people like the bicaval. I personally like the bicaval, but it really doesn't matter. It's whatever I think we're gonna, whatever is. agreed upon between the catheterizer and the imager before. I think you can see the left disc, if I'm not mistaken, right now with a little bit of an angle.
Let's go to LAO projection.
Mario, you have one of the greatest imaging persons in the lab, but would you alone, do you have one of our colleagues in imaging helping you driving a device?
Well, actually, let's go in AP because Aki, we don't want to hit.
It's okay.
So you rotated it
Yeah,
to the right.
but
Aki, we see the device on fast. Can you go to short axis or bicable or something like this? You see the device is perpendicular to the
Yeah.
septum, so we don't like to have this.
yeah, we don't like this position.
Right. So what I can do is go into the right upper pulmonary vein. Can you see that in fluoro?
Yes.
Right. This is a technique when the device tends to slip through the defect. Deploy the device from the right upper pulmonary vein rather quickly, and we will see. Stay in that projection, Aki, if you don't mind.
Okay.
Here we go. You see the quick deployment of the device coming down from the right upper pulmonary vein, and apparently it was successful in this case as well. So, right,
I'm not so sure.
okay.
One second, Mario. I want.
Aki, it's up to you to
Oh, that's
Yeah.
comment on the position,
okay.
etc.
Now it looks better. I'm not so sure about the upper leg right there. You see, Mario, I'm a little bit concerned about one of the legs of the device. Yeah, that's better.
I'm pulling the device or doing a
Yeah. Okay.
push and
Looks like-
pull test or whatever you call it, Minnesota Wiggle or whatever. How do you call it done?
Okay, that's fine. Okay. Yes, please.
Looks like even posteriorly it looks fine with both the right disc too.
Yeah, yeah.
Aki,
This one
any
is
comments
fine.
on the device position,
Yeah,
the flow,
I think
etc.?
it's a little bit, since you still have the wire connected to that, I think it's going to tilt back to the position that we want once you release the device. I don't see any residual shunt here, and we'll go to
I
the
think it's reasonably good position.
Yeah.
I'd like to go to LAO
Yeah.
projection
I
for
think, I think we're fine.
Aki
definitely
agrees
say.
that the position is fine. Let's go to LAO to see the, where we can profile the device.
Okay,
Be careful.
yeah, go ahead.
Datemi qualcosa da sedere.
Move the machine.
So it looks like in
Sorry.
short axis it occupies most of the atrial septum.
Yeah,
Yeah,
I can enlargement.
it will straight once the
You
device-
see with the device there, with separation of the most anterior part of the disc. I'm pulling the device and on echo it's stable.
Yeah.
Yes.
Yes, it is.
So if you agree, I think we are ready to release the device. Okay.
Looks very good.
Okay. So we are going to release the device. Lucien. Okay. Release it.
Come on, straight. Boom.
Okay.
Perfetto.
As you see, the device, after releasing, changed the position, go back to
Yeah.
AP. So Aki will show the picture on echo. Okay, we
So I
don't
think
need
the device looks
fluoro
very good.
anymore.
There is no, you see both rims very nicely. The right and the left, sitting on the right and left appropriate atria. No residual shunt. These speckles in the device itself, it's what expected, and in 3 minutes it's going to disappear. And then we'll take a look at the other projection. Also here, very nice, the
Rita
atrial
J.
septum and the atrial septum on the other side. So 15 was the right decision.
Okay. So we are happy, no rhythm disturbances, no, nothing. I think the position is okay according to the echo pictures. So,
Just close to the mitral valve, but not.
yeah. A quick look to the mitral valve, Aki, please. It looks okay,
Looks
isn't it?
okay, yeah. I'm not worried. It's
Okay, you have any other question or comments done from you, the panelists, on the audience?
Questions from the audience?
Yes.
Yes, Giovanni.
Morning, Mario and Lucky. Actually, it's Case, and I think the right upper pulmonary vein technique is very good. You made the comment about checking that the cable is stuck to the device, and I think when you're doing that technique, it's probably important to check again if you have to repeat the procedure, because the cable can get unstuck as the device comes from the pulmonary vein into the atrium. So if you're not successful like you were first time round, you have to do it several times.
Yeah, that's right.
The cable can get unscrewed.
Yes, we've been very quick, so I was not very worried about the possibility of unscrewing the device, but you're absolutely right. When you cannot get a good position on the device and you have to do several manipulations, etc., I agree with you that it's very important to be absolutely sure that the device is securely stuck with the delivery cable, yes. And in addition, I think that if too much time is passing by before releasing the device, there is also an additional potential risk of clotting, forming clotting in the sheath. So you probably sometimes it's better to get the device out, flush the sheath, and start all over again with 100% certainty that there is no clot in the sheath. Yeah.
So, are there special views or things that you would like to see with regard to the question of erosions and things like that? How you want to try to make sure that this device is not too pushing to the wall of the left atrium as a particular concern?
Well, in this particular case, I think the risk of erosion must be very, very low, because it's a relatively small or moderate size defect with very nice definite rims, no pushing against anything. So I don't think that, of course, we cannot exclude 100% this risk during long-term follow-up, but I think this risk in this particular patient is going to be very, very low. Any comments, Aki, about this?
No, I think the device sits very well, and as we can see, the amount of color in the mesh of the device is disappearing as we talk, and I think it's, as I said before, 15 was the right decision.
Okay, 15 was the right choice, and I think this is it. I'd like to thank everybody here in my cath lab, Lucien, Luca, all the techs, and Lina, the anesthesiologist, and Aki, Angelo, and Francesca. And so thank you very much for your attention, and I'll catch up in the conference room.
Okay.
Okay,
Thank you very
bye-bye.
much. Beautiful. Beautiful.
So we come to the first lecture, and this is given by Karl Balkamp, and the title is Data from the Literature and Registries Concerning Aortic Coarctation.
Good morning. It is a pleasure to be here, and I'm thankful to the Congress organizers for the opportunity. We do have a lot of data to review, so if I skip